Thank you, Will. It is a pleasure to be here. Thank you for the organizers for inviting me. So I want to start with a look back. The Framingham Heart Study is something near and dear to many of us. Was a practicing internist, used the Framingham Heart Scores, things like that. It began with a modest number of individuals, around 5,000 people who were followed longitudinally, and many measurements were taken. And this, along with many other observational cohorts, really gave us foundational knowledge about smoking, exercise, diet, the impact of high blood pressure, and how we could change those as modifiable risk factors to really improve survival, morbidity, and mortality from many chronic diseases. In this case, you can see that these fundamental knowledges and interventions have led to about a 60% decrease in mortality from cardiovascular disease. And so, the vision here is to think about precision or personalized medicine and how we can bring big data, wearables, genomics, other omics, and achieve a similar sort of improvement in mortality and quality of life, I would say, for the population, and hopefully in a much more rapid time frame. We certainly have seen many cycles improve. In thinking about this and thinking about wearables, and I'll tell you, I've actually used this example since before all of us began, in thinking about how we could measure devices and use things like wearables to improve care. I'm reminded of maybe an early wearable, the ECG, electrocardiogram. So in the 80s and maybe a little before, we're building this body of evidence that these extra heartbeats, as the third heartbeat here with the widened, what we call QRS interval, that these extra heartbeats, the preventricular contractions, portend bad outcomes. They're risk factors for myocardial infarction, fatal arrhythmias, sudden cardiac death. And we know that there are classes of medicines that will make a difference. These antiarrhythmics coming out do a good job at suppressing ventricular ectopy. And ectopy is bad, so we should fix it and put people on medications. And that's happening at this time. It's not advancing. There we go. But a landmark study in 1991 showed that, yes, you could effectively suppress this ventricular ectopy, but the outcomes were bad. More people died as you suppressed the ectopy. And what I use this as an example is a cautionary tale of the importance of not just getting lots of data, but connecting it to real clinical outcomes that matter to real patients. And I have to say, I'll come back to this, but I love that we began, Margaret, with your story, Layla's story, beginning with patients first and how we really make a difference here. All of us began with the mission to accelerate health research and medical breakthroughs, enabling individualized prevention, treatment, and care for all of us. It starts with nurturing relationship with participants as partners in the program. Before we did anything, we had 77 community engagement studios, which are like focus groups in 17 different cities with 16 different identified populations in those cities. We asked core questions. In fact, the reason it's called All of Us is before that it was the Precision Medicine Initiative cohort program. Rolls off the tongue, right? Participant told us that didn't mean much, and so the name All of Us was born. We asked what would be value, and things like getting information back was part of that. And so we want to have longitudinal relationship with participants in this program to really engage across health inequities, engage across all populations in the United States. We want to get this research data into as many researchers' hands across the world as possible to make discoveries. And we want to think of this as an ecosystem of researchers, communities, and funders, and to make health better, and this to be indispensable in health research. As we think about the overview, this is in one slide, what the program does. So we have enrolled about 870,000 people across the United States. We represent all US states and most US territories. People can really, truly enroll from everywhere. We have 98% of the ZIP-3 zip codes in the United States represented. Those people contribute in different ways. About 600,000 have given biospecimens. It equates to 14 million biosample aliquots, millions of survey responses. 95% of people say you can have my electronic health record. We do not have the NHS in the United States. So collecting those electronic health records is much more challenging. But we've worked with many different partners across the country, and we have approaching 500,000 electronic health records, which we have collected across many different EHR vendors, many different systems harmonized and made available to researchers. We have about 21,000 researchers across the world using this. I will encourage all of you who are not from the United States, as well as those from the United States, that we are open for business, and it's a very rapid process to come on. So I encourage you to use these data. Over about half of our publications actually came in the last year. It's growing exponentially, and we give information back to participants. The first thing they said they wanted back was genetic information and pharmacogenetics and health, germline health risk genetics. And so we give information on about 59 genes in different settings. Hereditary risk of breast cancer, hereditary cardiomyopathies, arrhythmias, things that we can do something about. And that's resulted in about 5,500 learning of potentially life-saving results that they can do something about. Those are all actionable. And about 150,000 have chosen to receive pharmacogenetic information that is actionable as well. As you look at the data we've collected, this is what's currently available to participants, researchers, about 2.9 million surveys completed, about 400,000 electronic health record data that we've curated and released, about 500,000 with physical measures, and the biospecimen will be becoming accessible to researchers. We have a number of different assays that we're working on, but haven't been released yet. We've called structural variants across our whole genome sequencing data of about 400,000 people as well, and those are available. So of those 400,000 whole genome sequences, we've observed about, I think the number is about 1.4 billion genetic variants, and about several hundred million of those, about 300 to 400 million of those were not in dbSNP at the time. So a lot of interesting data there, but of course, in this conference, we're thinking about wearable technologies. And so we're approaching 60,000 people that have wearable data. And right now, that's exclusively Fitbit devices. And I'll be talking in the next slide about how we're expanding that a little bit. So this just shows in our last two data releases and our upcoming data release in light blue. So the next one's going to have 750,000 people with survey responses, about 535,000 whole genomes. And then if you go look at the wearable section, we will be adding Apple Health Kit data to that as well. And so between that and the Fitbit devices that people have shared, that will bring us to about 80,000 people for which we'll have longitudinal wearable data. We've been generating other kinds of pilots around omic data, like proteomic data, RNA-seq data, metabolomic data. We have these deep relationships with our many different healthcare systems, and so we've been starting to work on getting clinical narrative data, which includes like radiology reports and discharge summaries, history and physical documents, things like that. We're doing a pilot with that, and we'll start with first natural language processing extracted concepts, and I mentioned, I think, proteomics already. We have some increasing our long read sequencing, including methylation in there as well. And so our data, even though we began in 2018 nationally, our data is longitudinal. When people share electronic health record data, we do attempt to get as much of that data as we can going back in time based on their consent. And so that in some cases goes back to 1980. The Fitbit data is the same, that many of that has provided longitudinal data. A lot of these are bring your own device linkages in that process. And as you look across our different disease states, we have seen that we are actually, in contrast to like the UK Biobank, we are sicker than the general population. A lot of our people have enrolled through hospital clinics, some even in inpatient settings, but most of it is certainly an outpatient. People can enroll from anywhere, anytime, just hit the website and sign in. But in general, we found that our population seems to be sicker than the general US population. It is all ranges over 18. We have some centenarians that have enrolled as well. And then you can see, so the distribution of different conditions here. So our Fitbit data, you saw the dot plot before, and this is another way to look at it, the number of participants, and then those for which how much data we have and the cumulative days of data. You can see that big increase on the far right, and that was us distributing devices. So as was mentioned earlier, the people who tend to have Fitbits tend to be higher socioeconomic status. We are over 80% underrepresented in biomedical research. We're about 50% of genetic ancestries other than European similarity. And so we do have really all populations represented, rural, different ethnicities, disability, about 20%, I think, claim a self-identify with a disability. So we have all populations represented. And so we gave out devices to people who were underrepresented in biomedical research to try to close some of that gap. I would love to give out a lot more devices and continue to increase that number and get better representation. Of course, the power is taking these data, as I referenced earlier with the EKG findings. The power is when you link this to other types of data. This is some great work, and I'll share some of her work later from Evelyn Fulda, who is a DPhil student in the NIH Oxford program. Aidan Doherty and myself are her co-mentors. And this just shows a little bit more detail on the duration of Fitbit data that we have, the percentage of people with data, and that goes across both of those data sets. So the people with the devices we gave out, of course, have had those for a much shorter period of time. We are finding most of those people are keeping them on at that 1 year time point that we've now been able to look at. But it obviously shifts that curve towards a shorter time period because we gave out a bunch of devices there. And so, but a lot of people do tend to use it on a regular basis, which I think will enable some different kinds of analyses that you'll see later. This is a public data browser. Anyone can go look at this on a smartphone, on the web, no login required. It gives a little bit of a demonstration of what it's like to query our data. And so we use a common data model across it. So if you search for something like cancer, you get mappings through ICD-9, ICD-10, SNOMED codes, those different kinds of terminologies through a common data model to look hierarchically across the diagnoses we have. And the same thing happens for medication data that we get through different sources. As you look at the researcher platform to actually do work and do access real level data to do research analyses, that's what we call our researcher workbench. It's a cloud-based model. All work is done in the cloud. We don't let you download the data, and that's part of our contract with our participants. Also, the size of the data, it starts to get hard to do so anyway. But it is a way to really, we think, enable much faster access to data, as well as providing better security and safety and privacy protections for our participants. So people come in to do it. Once you are approved as a researcher, you have a passport to do any kind of research. You declare what that's related to health. You declare what that is, and then you can get started immediately. Those researcher descriptions are available to our Resource Access Board. We can monitor them kind of asynchronously. We're doing different technologies to do that based on the questions you answer. And of course, looking to apply AI technologies to help us monitor as well, to look for things that potentially are stigmatizing research and to protect the population that's given of their data in this process. There's no separate IRB needed. So really, you can come on and start doing work. If you've never logged into the site before, if you're one of the 1,300 institutions that has approval right now, you can come on for the first time and then start writing code in an hour and a half. If you go through the steps linearly, answer the questions, do the training, pass the quiz. Not everyone passes the quiz, but you get to retake it if you fail, don't worry. But if you get through that, you get to get started very quickly. Right now, we have about 21,000 researchers, as I mentioned earlier. It's only 1,100 internationally. We opened internationally later. And so one of my big calls out here is if you are international, we're open for business and we invite you to come in. We are seeing about 1,300 organizations. It takes about a month typically to onboard a new organization. It can take longer internationally. The UK is the best represented right now, international country. We do have all 7 continents, though. We actually had someone use it from Antarctica. About 22,000 projects and about 1,200 publications. Looking at the publications, here's a snapshot of some of the wearable publications. I'll dive into some in a little more detail. We have an online publication directory, and you can search through that. Most of our research so far has, and most of the current projects do involve some sort of genomics. So I would be remiss without saying a little bit about genomics, but I'm going to move off of it quickly. So this is an example of a study that I did in a network in 2011. We looked at hypothyroidism, primary autoimmune hypothyroidism, presumptive Hashimoto's thyroiditis, and we identified one locus that was associated with this. I just highlight this. It took about 40 people working in these different EHR systems to do the queries to harmonize those data analyses, to put the data together. Took us about 2.5 years to do it, and lots of grant awards. And I had a postdoc come into my lab, or sorry, post-bac, who's now a medical student, come into lab in 2023. And I just said, this is fresh out of July, no computer science training, no genetics training, and say, to get introduced, how about you take this paper and try to replicate it in all of us? And so, you can see the figure there. It's much prettier. It's part of a meta-analysis, which will come out soon in Nature Genetics. And he found many more signals. One of the interesting things you see here is it took him about 6 weeks. I wasn't timing him. You could actually go straight through probably much faster. But, this is just a post-bac starting, reading a paper, figuring out how to do everything on his own, and with a very distracted at oftentimes PI and myself. And it took him about $40 of cost to do this analysis. The other thing that's interesting is you would think in that 12 years of time, there would have been many other studies that looked at diverse genetic ancestries in that time. And actually, there hasn't been. So even though there's been a lot of time passed, more than 90% of all genetic studies, as many of you probably know, have been done with European genetic ancestries. And so we really are seeing a big uptake in that, but this is just yet another example of how having a diverse genetic resource out there is leading to and helping, I hope, fill that gap. That's a very important one. So moving to wearables, this was the first big wearable study. It came out in all of us. At this point, they had about 15,000 individuals with Fitbit data and electronic health record data. The PheWAS on the left, or phenome-wide association study, you can see the protective phenotypes on the left and the ones at risk on the right. Many things are protective in this more cross-sectional prevalent analysis. And then they took some of those and did them in a more of an incident diagnosis design. And you can see something that was very relevant to me as a primary care doc. You don't have to get that patient to 10,000 steps a day. If you could increase them from 2,000 steps to 4,000 steps a day, there's a difference for some of these common conditions in terms of outcomes. This is another study that gets at the value of having really that continuous longitudinal as opposed to that 7 days of analysis. So I guess, advertisement to have this longitudinal data available. And so when you look here, these are people with the earlier data set than the 59,000 that we have now, identified 512 participants who had surgeries, 600 plus surgeries, and then classified them based on risk, and then looked at different impacts on sleep here. And you can see some of these different flows here based on time. And one of the things that you see is the higher risk surgeries do disrupt sleep more and over a longer period of time. But one of the other things I thought that was really interesting is being able to also look at opioid exposures and see that those increase light sleep. So, to the observer, they may look like they're getting more sleep, but, disrupted REM and deep sleep. And of course, there are many more patients now. You could do the same analysis. Here's another with wearables and pregnancy. And so I don't know if you know, there's a lot less research on pregnancy, actually. And it's one of those women's health topics that is not as explored as much. And because we have a lot of people with longitudinal data, you can look at some of these, maybe just topics of interest, but there probably are health impacts in the changes in steps per day. And how long does it take to get back to where you were before? And you can see that here as you walk across the activity and delivery to their activity level. And then sleep, I think none of us are surprised that the sleep is quite disrupted with an infant at home, and how long it takes to get back to where you were before. And so we're looking at a year or two to kind of return to baseline activity, and what are the variation in that, and what are the variation in that, and what is the impact on health. Going back to Evelyn, our wonderful DPhil student, I just want to highlight some of her work. And so one of the things she's been doing is she's been looking at different phenotypes as well, not just step count. So, and this paper is on medRxiv now and in review. One of the phenotypes she looked at, in addition to step count, was peak 30-minute cadence. She also looked at different windows of time. If you do it for 7 days, you do it for 1 day, you do it for a month, you do it for a year. What is the added value of looking at towards that time? And you do gain value. In this case, we're looking at 1 year of step count, or sorry, peak 30-minute cadence data. She's produced this for each of these different activity phenotypes and looked at ones that look at like prevalent associations and ones that are, we'll say, maybe incident-like exposures. And so if you think about that, some of those are early markers of disease. For instance, you see some autoimmune diseases here that are associated, and rheumatoid arthritis and other autoimmune diseases. That may not be an incident diagnosis. That may be an early marker of disease before the physician has diagnosed that patient with that condition. And obviously, we can continue to go with these. There are hundreds of associations, as you can tell here, that are associated in both prevalent and incident style analyses. Coming back to genetics, I always ask myself, what is the really translation to impact? And this is one of the early translations to impact that we've seen is there is a clinical polygenic risk score test that is now available in the United States, available to any provider to order and test. And importantly, getting back to that diversity question, it was trained on all of us. It does represent all prevalent genetic ancestries in the United States, and then validated, of course, in another population, importantly. This is what the test PDF looks like, and it covers 8 cardiovascular conditions that you can see listed there. And so we hope that this obviously continues to grow. We are looking to continuously expand our data set. We're working on data linkages now, filling in some of those EHR data gaps, adding data on things like really important outcomes like mortality, claims data if we can, geocoded based information on environment and other types of data related to that. We are a platform that other people build on. Hopefully you saw that also clearly with researchers, but it's also building ancillary studies, or what we call partner research studies. We have a number of these going on, about 20 in process. I'm highlighting 4 here. The biggest of these is Nutrition for Precision Health, and that's adding metabolomic data, diet randomization data, and outcomes with those. Training of, for instance, people wear glasses that take pictures based on chewing of their food, and that can be used to train AI models, for instance. We're looking at environmental risk factors for people who develop diabetes since they enrolled in the program. We're capturing retinal images in a handful of sites, and we're actually looking to bring back people who have, it looks like, potentially novel genetic syndromes, as well as potentially some undiagnosed genetic diseases. We will be offering soon what is an EXO-1 mechanism. That's a grant mechanism that doesn't come with funding, but it gives us a competitive process to access our biospecimens. So far, biospecimen access has been limited to within the NIH and driven projects. We will be allowing, when this EXO-1 is released, the ability for outside investigators to apply with good ideas to access our biospecimens. And we have DNA, RNA, cell-free DNA, plasma, and serum, as well as urine. Starting to use the workbench is pretty easy. Here is this basic 6 steps here. The first step is having institutional access. Once you have institutional access, those next steps can be completed, as I said before, in about an hour and a half or 2 hours if you go straight through for most people. It includes identity verification, some specific training, and then a quiz on our program. So as we think about going forward, there are a number of partnership opportunities out there. And I mentioned the access to biospecimens. I am really hoping to find ways to continue to increase those who have wearable data. We hope to bring in the ability to connect other types of devices more over time. I mentioned we'll have Apple Health Kit coming in the next release. And obviously, we encourage people to have devices to connect to them. Given that we are a more diverse population, socioeconomically and otherwise, than the general population, you mentioned that maybe I think you said 20% or 30% of the U.S. may own a device. Our number is going to be lower than that. So, we need to close that gap through other mechanisms, and hope to continue to do so and get better representation. We also have talked about, ways to encourage people in the US to enroll that have devices. I already mentioned the partner research studies. And then the last thing I'm just going to mention is data challenges. And many of you are probably thinking about this in different ways, in different outcomes. One of the things that, just remember is one of the Nobel Prizes in 2024 was for protein folding prediction. And, that was based on decades of protein folding competitions that were set up and the way the community organized around that to support that. And so I think as we entered another realm of new and rich data sets longitudinally that could be mined in so many new ways of mining it with clinical outcomes, it's something else to think about as we go forward and use our data in that way. So with that, the last thing I'll say is we have our annual Science Day that we are restarting on April 15th, which is actually tax day in the United States. So everyone in the program has to get their taxes done early, I guess. But I invite everyone to join. We'll be giving updates on the program. There'll be a lot of scientific talks at this, as well as keynotes from Naomi Allen, who is the Chief Science Officer for the UK Biobank, and Pradeep Natarajan, who was partially responsible and a driver force behind the clinical polygenic risk score test I mentioned earlier.